My name is Monique Gary. I am a breast surgical oncologist and director of the cancer program at Grandview Health in Sellersville, Pennsylvania. And I am an associate professor for race and health equity at the Dartmouth Institute for Health Policy and Clinical Practice associated with the Dartmouth Geisel School of Medicine. Today, we're going to briefly touch on addressing health disparities in survivorship care for underrepresented groups. I have no relevant disclosures. So let's start with how we define a cancer survivor. The National Coalition for Cancer Survivorship says that survivorship starts at the very time of diagnosis, and it proceeds along a continuum through and beyond treatment, through recurrence, through cures, final stages of life regardless of cause. And the extended definition most recently includes now caregivers, family, and friends, and all these people are considered part of the survivor ecosystem. When you look at the numbers of U.S. survivors by site, in 2024, we're estimating that approximately 41% of female breast cancer patients will be survivors, 3.9, almost 4 million, colon and rectum as well, uterine, melanoma, etc. And you can see all sites, the numbers of survivors when compared to, say, 10 years ago. 2014 has grown exponentially. If you ask a patient what survivorship looks like, there's a range of their experiences, their lived experience, and their goals and expectations that really is a little bit different even than our clinical goals. And it may be living cancer-free for the remainder of their life. They may live cancer-free for years and have serious and latent and long-term complications of their treatment. Cancer-free, but having a recurrence or having intermittent periods of disease and psychosocial distress associated with those things. And so there are some goals, but survivors, we know, may experience over time confusion regarding what's happened to them, confusion over the management of their side effects, confusion over who to see and when to see them, and difficulty with accessing those issues, difficulty with financial toxicity, and the issues regarding treatment and surveillance. And so when we consider the survivorship needs, we really have to consider those factors that contribute to overall quality of life. And this is a great study with permission from GW and the American Society of Clinical Oncology that looks at the components of that survivor's quality of life, their functional well-being and status. Are they sleeping? What is their fertility? How's their pain? Their psychological well-being, their social well-being, their spiritual well-being. And these are really in alignment with the overall circles of wellness. And what does this mean for us as a cancer program and as a medical society? It really means that we need to look at things both at the microscopic and at the macroscopic level, beginning with the cancer survivor, but then looking to our systems to see what systems can we put in place, what policies, what procedures, and what resources can we offer cancer patients at the system level. And then at the institutional, at the society level, and at large, what are some of the policies that we might implement that help survivors better access survivorship services? And I think this is a really exciting time right now. We're going to talk a little bit about what's happening in 2023 to address these things from a policy level. But now is the time. The pathway to better understanding survivorship really started in 2006. The Institute of Medicine issued this groundbreaking report from cancer patient to cancer survivor, what gets lost in translation. And they outline the core components of survivorship care and begin to recommend a treatment summary and a care plan that should be given, and that care plan should be properly explained. And it wasn't until almost 10 years later that the requirement for that was instituted in cancer centers around the country. The American Cancer Society, in conjunction with the American Society of Clinical Oncology, or ASCO, began in 2015 to now make some recommendations and guidelines from a national standpoint. And the practice guideline really sought to address 5 key areas of, in particular for breast cancer survivorship, and breast as the model for others. But the 5 areas included surveillance, screening for secondary cancers, assessment and management of the physical and the psychosocial long-term and late effects of treatment, health promotion, and then care coordination. And so with breast as the model, we began to roll this out for other cancers as well to really address these areas of survivorship. And that sounds wonderful. We developed an actual care plan that cancer programs now are required to use. The requirement for survivorship care plans has morphed over the last even 5 years, but all cancer programs are required to give patients a summary of who their providers are, what treatment they had, what their stage, what their surgical course, their medication, radiation, etc. What are some of the anticipated side effects? Who are the resources for them to manage those? And then what does ongoing management look like? And all of this is placed into a document that's then reviewed with that patient, and it becomes a bit of a living document as the patient goes back to it year after year to better understand how their management changes for both their cancer and for their chronic conditions with respect to their overall cancer journey. And so these basic elements of survivorship are really, the goals are to look at prevention of late cancers, look at surveillance, identify interventions for the consequences of their cancer care, because we know that cancer treatment itself is not without side effect, is not without consequence, is not without some expected and unexpected elements and events. And then really struggling to look at coordination between oncology specialists and primary care providers. A key example of this is something like glycemic control, which during cancer treatment can really become compromised and need special management. But then when patients are finished their treatment, how are we translating the information back to their primary care providers? How are we managing glycemic control for these patients who are now off steroids and who may have some issues with A1C, issues with movement, issues with chronic obesity? And so the coordination between specialists has never become more important than it does for a cancer patient. More recently, in 2022, the American Association for Cancer Research released a Disparities Progress Report outlining some of the challenges and really setting forth the agenda for a bold vision for health equity for racial and ethnic minorities. And this includes the topic of cancer survivorship. They highlighted disparities in the burden of preventable cancers, including lung cancer, highlighting the decline in breast cancer-related mortality, although that decline does not happen at the rate comparable with white and with other racial and ethnic minorities and other majorities. When we look at disparities in cancer clinical trials, we can see that in 2020, 53 novel drugs were approved for several diseases. However, the participation in clinical trials of racial and ethnic minorities continues to not represent the overall U.S. population, certainly not the burden of disease. And there is a disparity in participation in clinical trials that thus translates into also a disparity in overall mortality and in morbidity as well, in presentation of advanced and delayed disease. When we look at the LGBTQ community, there is certainly a complicated conundrum of disparities across the continuum, looking at both risk for their cancers, risk for screening, risk in treatment, and even risk into survivorship. When we look at some of the survivorship challenges, however, at the Out for Health survey occurred in 2021 and is probably the most inclusive survey of LGBTQ patients of color in particular who are dealing with cancer of all kinds. And they queried how well your cancer programs addressed your needs. Were you offered access to clinical trials? Did you feel supported in your cancer center? Do you have social support? What access issues do you have? And when we look at survivorship, did you talk with your provider about a post-treatment care plan? 55% said yes, but an astounding 45% said there was no conversation regarding what happens after treatment and what life should look like. And if yes, a treatment plan was included for you, was that treatment plan tailored to your specific concerns, your specific needs, your lived experience? And a resounding 87% said no, their post-treatment care plan did not include resources specific and unique to the LGBTQ population. So this is certainly an area of increased research and an area for improvement. While every cancer survivor has a unique experience, the medically underserved populations really do shoulder a disproportionate burden due to the disparities, again, across the continuum, with things like navigation, with things like financial toxicity, nutritional support, psychosocial support. And understanding the challenges within these groups are going to help us inform the care strategies and really better personalize the recommendations, but also begin to strategically develop the entry points for structural change in access and in services that we provide. A really great example of this is highlighted in AACR's report. Black and Hispanic patients with cancer, they have increased use of financial coping behaviors. And this means they skip medications because of the financial impact of their medications on their overall quality of life and on their ecosystem, on their family dynamics and family finances. So this certainly, the disparity in access translates into the disparity into survivorship. The challenge is that there's very few randomized controlled trials that really test interventions, and breast is probably the most common and the most dominant. But when we look at the issues in survivorship, they're institutional, they're regional, they're social, and they're coming from advocacy groups. But the amount of data, empiric data from our societies and from our cancer community really needs to be addressed. It needs to be supplemented, and we need to strategically look at the challenges and the barriers in both access and utilization of survivorship services. The majorities of these citations are, looking at case-controlled studies, some cohort studies, some population data, but I think that we can do a better job of strategically outlining what those challenges are. When we rely on previous guidelines for surveillance, for symptom management, I think we miss the opportunity to include individuals who were not included in those guidelines. And so we continue to potentially further disparities in data collection, and we further exclusion when we do not consider those populations. What I'm saying is that if the guidelines are based upon populations who are disproportionately affected by disease, by doing review of the data, we then produce guidelines that continue the disparity. And the recommendations are based on current evidence, and there's not evidence to warrant strong recommendations, and we see this across the board. If we have limited data, we review the limited data, we continue to say we have limited data to suggest a possible intervention. And so surviving and thriving starts at day one. For that survivor, we really need to look at diet and exercise interventions, clinical trials, both during and after treatment, the quality of life, the level of health literacy, community education, and financial support so that that patient can cross the bridge into survivor. There are some models that are beginning to look at this in a really strategic way. And the goal for the population of survivors, we want to refine that chronic disease management. We want to develop some evidence-based and culturally appropriate information to meet those needs and increase awareness of the existing resources. We need to increase utilization of existing resources. At the systems level, developing those care guidelines, and then at the policy and at the society level, making sure that those services are reimbursable. I practice in a community center, and while we offer many survivorship services, whether or not patients can access and can afford those services and whether or not those services are reimbursable impacts the availability and the abundance of those resources. A really great resource came out of the Cancer Survivorship Center Education.org. They developed an e-learning series, and this is for primary care providers, but it is certainly extrapolatable to specialists as well, looking at the current state of survivorship and the role of the provider, the late effects of cancer, and how to manage the comorbidities, managing the psychosocial needs of those survivors, looking at the importance of prevention and empowering survivors to live well, taking the team approach, looking at recovery and rehabilitation, and really spotlight on what are the clinical care and the follow-up guidelines that primary care should be aware of. And I think this is a wonderful model to begin to extrapolate to other professions and other specialists as well. There are some great guides for delivering quality survivorship care. The George Washington Cancer Institute has a beautiful tool accessing survivorship and developing programs for that. And then moving beyond patient satisfaction, what are some of the tips to measure the impact? And this is especially important in the community cancer setting where we need to show the return on investment, the cost-benefit analysis, the impact on outcomes, and the feasibility and scalability of delivery. And these are all critical considerations as we look at survivorship and ways to address barriers and disparities. The American Cancer Society has taken bold steps by the establishment of roundtables that are designed and charged with integration of guidelines, delivery services, addressing barriers for cancer patients through screening, treatment, and into survivorship. In 2022, the National Breast Cancer Roundtable was established, and we are really charged with developing high quality, compassionate, and then culturally appropriate resources to make sure that patients have what they need through their survival, to look at quality of life, and to really highlight both the barriers and the strategies for overcoming the barriers, whether they're rural, whether they're underserved, under-resourced communities, whether they're special communities like LGBTQ populations, but making sure that every center has the resources and a strategy for implementation of the resources, not just through screening, diagnosis, and treatment, but with a keen focus on survivorship as well. And what that roundtable looks like, we had a meeting just this week. They've done some formative research, finalizing the priorities. We've convened the working group, and we are now beginning to look at the data that's available, to identify the areas where we really need more data, and then to begin to put together task groups and strategies and recommendations for cancer centers all across the country that are going to address the topics of things like survivorship access. And our takeaways are that we need more data. We need programs, we need investigators to begin to look at the issues in both navigation and utilization of survivorship services. We need innovative pathways to begin to measure those barriers and access to those resources. We need to look at the limitations of reliance on previous guidelines for surveillance and symptom management, because for certain populations, particularly in breast cancer, young women of color, the guidelines and the recommendations for surveillance perhaps are not as well suited for them. And in the setting of insufficient or limited evidence, we must encourage community collaboration. We must encourage innovative approaches, and that needs to be published, and it needs to be made available for all centers so that we can better identify where the opportunities and the strategies and the best practices lie. And with that, I'll stop. I think we're going to take questions and have some discussion, but I thank you so much for your attendance and your participation and interest in this discussion.